Ask the Orthotist. Brought to you by Strive Orthotics and Prosthetics.
So you've sent us an absolutely incredible stack of medical literature today. I mean, looking at this, we've got World Health Organization growth charts, FDA criteria, clinic guidelines.
It's a very comprehensive pile of data. Yeah.
Right. And it's all centered around one incredibly stressful topic for parents, which is baby head shapes.
Oh, absolutely.
Yeah.
It causes so much anxiety.
It really does.
Right.
So our mission for this deep dive is to basically play Ask the Orthotist. We're taking all these sources you provided to get definitive answers to 3 massive questions that families face.
Which is exactly what we need to do, just cut through the noise.
Exactly. So number 1, what is the absolute best age to evaluate a baby for cranial helmet therapy? Number 2, can parents afford to wait a few months to see if a flat spot improves naturally, or, is that a dangerous gamble?
Right, the whole wait and see approach.
Yeah, and then number 3, if a family discovers the asymmetry later on, say past the first few months, is it ever too late to benefit from a helmet? Have they just completely missed their window?
These are such common real-world anxieties because families will notice their infant's previously round head is developing this flat spot on the back.
Or like the ears look crooked suddenly.
Exactly. The ears look misaligned. And the immediate fear is, oh no, I've done something wrong, or I'm missing a critical window to fix this.
Okay, let's unpack this. Because before we can even talk about when to evaluate a baby's head shape, we really need to understand exactly what we're evaluating in the first place.
That's a great point. The mechanics are crucial here.
Yeah, your sources make it clear that time is of the essence. But to really grasp why, we have to look at what's actually physically happening to the skull.
Right, and that's the critical starting point. We have to distinguish between 2 completely different underlying mechanisms that cause an uneven head shape.
Okay.
So the first one, and by far the most common, is positional plagiocephaly.
Plagiocephaly, okay.
Yeah, and this develops after birth. An infant's skull is, it's highly malleable. It's made up of these bony plates that haven't fused together yet.
Right, so they're soft.
Very soft. So if a baby spends a significant amount of time lying in one position, the external mechanical pressure, like against a firm mattress or a car seat, it physically flattens the soft bone.
Got it.
If you were to look down at the baby's head from above, it often takes on the shape of a parallelogram.
A parallelogram. So it's purely a structural shifting just due to gravity and surface pressure? Like the bones themselves are just sliding and adapting? They aren't prematurely fused or anything?
Precisely. It's an external pressure issue. But the second condition is craniosynosis.
Okay, that sounds more serious.
It is. That's a birth defect, where one or more of the cranial sutures actually fuse together way too early.
Ah.
Think of the sutures as the expansion joints between the skull bones. In a healthy infant, those joints have to be open to allow their rapidly growing brain to push the skull outward.
Right. So if one of those expansion joints is glued shut, the brain still has to grow somewhere, right?
Exactly. It doesn't just stop growing.
So I imagine the skull is just forced to expand in totally unnatural directions just to compensate for that roadblock.
That is the exact mechanism, yes. So instead of a flat spot caused by a mattress, you'll typically feel a very firm, bony ridge along that fused suture.
Oh, wow.
And the resulting head shape follows very predictable abnormal patterns. It depends on which specific suture closed early.
So it might look completely different than just a flat back of the head.
Right. It might result in a really distinctly long and narrow head, or maybe a sharply triangular forehead. And unlike plagiocephaly, craniosynosis usually requires surgical intervention.
No, surgery.
Yeah, surgeons have to manually open those joints to relieve the intracranial pressure and just allow for normal brain growth.
Okay, but if craniosynostosis requires surgery to physically separate the bones, and positional plagiocephaly just requires a helmet or like repositioning, a parent can't be expected to make that diagnostic call at home.
Oh, absolutely not.
If I see a ridge or an ear shifting, I'm not going to know if it's gravity or a fused bone.
And you really shouldn't try to guess. While a specialist knows how to differentiate that compensatory growth from a fused suture versus the, parallelogram shift of flattening, a clinical evaluation is the only definitive way to rule out craniosynostosis.
Right, you need a professional.
Often a craniofacial team can diagnose it through a physical exam, but they'll frequently utilize 3D imaging, or a low-dose X-ray, or even a CT scan.
Just to be totally sure.
Exactly, just to confirm beyond a shadow of a doubt that those expansion joints are actually open. And that leads directly to the timeline of when to seek that evaluation.
which tackles our first core question. Based on the clinical guidelines in this massive stack of sources you sent us, the ideal golden window to evaluate a baby is between 3 to 6 months of age.
Yes, 3 to 6 months. And if the clinical team determines that helmet therapy is actually necessary, the treatment itself typically kicks off between 4 and 8 months of age.
Okay, 4 to 8 months.
And that very specific window, it isn't arbitrary at all. It is entirely dictated by the biological reality of infant brain growth.
Because they grow so fast.
Unbelievably fast. An astonishing 85% of a human's postnatal cranial growth happens in the very first year of life.
That is wild. Okay, let me try an analogy here to sort of visualize the mechanics of this. Because the skull isn't really growing on its own, it's being pushed, right?
Right.
It's kind of like blowing up a balloon inside a cardboard box. The brain is the balloon, and it's expanding aggressively.
I like this, yeah.
So if the baby is lying flat on their back, the mattress acts like a rigid wall of the box. As the balloon inflates, it presses against that flat mattress, and it just can't expand in that direction.
Exactly.
So the volume simply bulges out in all the other unconstrained directions. The internal volume of the brain is exactly the same. It's just shifting the shape of the container.
That is a brilliant way to picture the physics of it.
Yeah.
And helmet therapy simply capitalizes on that exact same mechanism.
So it's not squishing the head.
No, not at all. The cranial orthosis doesn't squeeze the head or apply painful corrective pressure to the bulging areas. It essentially acts as a brand new, perfectly round box.
Oh, I see.
It holds the prominent areas gently in place while leaving deliberate empty voids over the flattened areas.
Right.
So as the brain continues its rapid expansion, it naturally seeks the path of least resistance and just fills in those empty spaces of the helmet, naturally rounding out the skull.
Okay, but that entirely relies on the brain actually inflating fast enough to fill the void.
Yeah.
I mean, if the balloon stops expanding, the new box doesn't do anything at all.
Precisely. And what's fascinating here is just how dramatically that biological inflation drops off after the first few months.
It slows down that much.
Dramatically.
Yeah.
The World Health Organization growth velocity standards in your sources plot this out perfectly. If we look at the 50th percentile for baby boys, from birth to 4 months old, the head circumference grows an average of 7.1 centimeters.
Over 7 centimeters in just 16 weeks? That's huge.
It's explosive growth. But now look at the very next interval, from 4 to 8 months. That growth velocity plummets to 2.9 centimeters.
Wow. That is a massive deceleration. And then I'm looking at the chart for the 8 to 12-month window, and it drops again to just 1.5 centimeters of growth.
Which perfectly illustrates why the 4 to 8 month window is the absolute sweet spot for a helmet. Yeah. You're actively harnessing that 2.9 centimeters of rapid growth to fill the voids in the helmet.
Makes sense.
If you try to reshape a skull at 11 months old, you are working with a structure that is hardly growing at all in comparison.
Okay, so the logic is super clear on the back end of the timeline. But if the brain is growing explosively in those earliest months, like harnessing a massive 7.1 centimeters of growth from 0 to 4 months, my instinct as a parent would be to demand a helmet on day 1.
Sure, get ahead of it.
Right. If I notice a flat spot at 8 weeks old, why on earth do the insurance guidelines you found ask us to hit pause? Why wait?
It definitely feels counterintuitive, but the medical protocol heavily favors a wait-and-see or conservative approach in those early months because positional plagiocephaly frequently improves on its own.
Just naturally.
Yes, as the baby develops motor skills. The Hutchison study in the literature tracked this natural progression over time.
What did they find?
They found that at 4 months of age, the prevalence of positional plagiocephaly was 19.7%. Roughly 1 in 5 infants had some notable asymmetry.
That's a lot of babies.
It is, but by the time those exact same children reached 2 years of age, without any helmet intervention, the prevalence had dropped to just 3.3%.
Wait, really? That implies the vast majority of these cases simply self-correct once the baby spends less time lying flat on their back.
Exactly. And this is the rationale behind criteria like the Interqual guidelines that are used by a lot of insurance companies.
Okay.
For an infant under 6 months old, the guidelines require a documented period of at least 2 months of conservative treatment before a helmet is even authorized.
I want to dig into the mechanics of that conservative treatment, though, because it's not just crossing your fingers and waiting, right? What are parents actually instructed to do during those 2 months?
Right. It's a very active process of changing the environmental pressures on the skull. It involves rigorously supervised tummy time while the infant is awake.
Which just takes the pressure off the back of the head entirely.
Exactly.
Yeah.
It also involves parental education on repositioning the infant's head during sleep. And, crucially, it often involves physical therapy for a condition called torticollis.
Ah, torticollis. That's when the neck muscles are tight on one side, right?
Yes. Imagine the sternocleidomastoid muscle on the right side of the baby's neck is perpetually cramped or shortened.
Okay, ouch.
Right, so the baby will naturally favor turning their head to the right because it's just physically uncomfortable to look left.
Which means the exact same spot on the back right of the skull is bearing the weight of the head 24/7.
Exactly. So conservative treatment involves a physical therapist teaching the parents gentle, consistent stretching exercises to manually lengthen that tight muscle.
Oh, I see.
Once the neck has full range of motion, the baby naturally distributes the pressure more evenly across the entire skull, and that allows the flat spot to round out on its own.
I'm tracking with you, but I'm going to push back on this timeline a bit.
Go for it.
If the Hutchison study proves that the prevalence drops from nearly 20% down to 3% naturally, and physical therapy is so effective at removing the underlying cause, why do we need helmets at all? Why not just stick with conservative therapy indefinitely?
Because biology has its limits, and nature just doesn't fix everything, especially when the deformity crosses a specific threshold of severity.
So it depends on how bad it is to start with.
Precisely. Your sources highlight a pivotal study by Kluba and colleagues that compared infants who received helmet therapy with those who strictly used conservative management.
Okay, what was the dividing line?
The dividing line was severity. They used a metric called the Modified Cranial Vault Asymmetry Index. For mild cases, which they defined as an index of less than or equal to 6.5%, conservative management without a helmet was highly effective.
I'm assuming the data looks very different once you cross that 6.5% threshold into moderate and severe territory, though.
Drastically different. In the moderate to severe group, the infants who received helmet therapy achieved a 68% improvement in their asymmetry.
Wow.
Yeah. But the infants in that exact same severity bracket who were only treated with conservative management, they saw a mere 31% improvement.
Meaning they basically hit a biological wall. If the deformity is severe enough, repositioning just isn't powerful enough to counteract it.
Furthermore, you're fighting a developmental clock. Once a baby reaches about 6 months old, they learn to roll over, they start sitting up, they move independently in their crib.
Right, you can't control them anymore.
Exactly. The idea of carefully counter-positioning a 6-month-old while they sleep is practically impossible. They'll simply roll back to whatever position is most comfortable for them.
Here's where it gets really interesting, because as I was reading through these clinical studies, I realized the medical community isn't just worried about a baby looking asymmetrical in family photos.
No, it's not just cosmetic.
Right. If a severe case fails to self-correct and you skip the helmet, there are actual functional physiological consequences.
There are significant downstream effects because the skull is an interconnected system. Think of the cranial base not as a separate dome, but as the foundation of a house.
Okay.
If the foundation at the back of the skull shifts and flattens, the framing in the front shifts right along with it.
Oh, wow.
The literature outlines how severe, untreated plagiocephaly pushes the cranial base forward on one side, which physically misaligns the jaw hinge.
That sounds awful.
It is. This is known as mandibular dysmorphology, and it can lead to long-term temporomandibular joint, or TMJ, issues. It alters how the child chews and speaks.
It also physically tilts the bony anatomy of the eye sockets, right? I mean, the sources mentioned documented risks of visual field defects because the eyes are just no longer resting on a level plane.
Yes, the structural implications are very real. The literature also brings up a study by Panchal, which observed that children with untreated plagiocephaly had significantly different distributions in their mental and psychomotor developmental index scores, the MBI and PDI scores.
Okay, we have to handle that specific finding carefully, because telling a parent that a flat spot on their baby's head is linked to developmental delays is incredibly anxiety-inducing.
Absolutely.
Does the flattened bone actually press on the brain and cause damage?
That is a vital clarification, and the answer is definitively no. It doesn't cause brain damage.
Oh, phew.
The researchers emphasize this is likely a case of reverse causality. A baby who has underlying mild neurodevelopmental delays may simply move their head less frequently. Because they're less active and less likely to spontaneously reposition themselves, they are far more susceptible to developing a severe flat spot.
So the plagiocephaly is a symptom of the low mobility, not the cause of the developmental delay.
Correct. However, the presence of all these compounding factors, the jaw misalignment, the visual field issues, the link to motor development, is exactly why medical professionals strongly advocate for helmet intervention in severe cases rather than just, hoping for the best.
Okay, so we've mapped out the logic. The 4 to 8 month window is optimal because we want to harness that explosive balloon inflation phase of brain growth.
Right.
We know that 2 months of conservative therapy is standard, but gambling on natural improvement for a severe case is just a losing bet.
Exactly.
Which brings us to the third and probably most anxious question from the listener's stack of research. What about the family who didn't realize the severity or perhaps faced delays getting an appointment, and now their baby is 10, 11, or 12 months old?
This is such a stressful situation for parents.
Is the window bolted shut? Have they completely missed their chance?
This is perhaps the most important data point in your entire stack of sources, because there is a pervasive myth, even among some pediatricians, frankly, that helmet therapy is entirely useless after 12 months of age.
Really?
Yes, but the reality is that the FDA has officially approved cranial remolding orthoses for use in infants, all the way from 3 months up to 18 months of age.
Up to 18 months. So the regulatory bodies absolutely acknowledge that treatment is still viable for a toddler.
Absolutely, provided the cranial sutures haven't naturally fused yet.
Right.
And to really put the 12-month myth to rest, we can look at a fascinating study by Grigsby, which was conducted at the University of North Carolina hospitals.
Okay, what did they do?
The researchers designed a direct comparison. They evaluated a young group of infants, those who had completed at least half of their helmet treatment before turning 12 months old, and they compared them directly against an old group.
So infants who are over 12 months old for the majority of their time in the helmet?
Exactly.
Well, based on the WHO charts showing growth slowing to a crawl-like, just 1.5 centimeters between 8 and 12 months, I would assume the younger group's results vastly outperform the older group.
That is the logical assumption, right? But the data actually points to a highly surprising conclusion. The researchers found absolutely no statistically significant difference in the total amount of asymmetry correction achieved between the two groups.
Wait, the older babies achieved the exact same structural correction?
Nearly identical.
Yeah.
The change in symmetry percentage for the young group was 6.61, and for the old group, it was 6.56.
That's statistically, they are the same outcome.
Yes. The authors explicitly stated that parents of older infants should not be discouraged from pursuing treatment purely based on the child's age.
I feel like we are missing a variable here, though. If their heads are barely growing, how are they achieving a 6.56 change in symmetry? Does the helmet apply more active pressure on older skulls?
No, the helmet functions the exact same way. The catch isn't the mechanism of the helmet, the catch is the timeline.
Oh.
The older babies absolutely achieve the same results, but because their cranial bone is thickened, the skull is stiffer, and that biological growth rate has slowed down so much, the treatment length almost doubles.
Ah, so they get there, but they just have to take the long, scenic route.
Yes. For the younger group harnessing that rapid early growth, the average time spent in the helmet was 3.62 months. But for the older group, the average treatment length stretched to 6.51 months.
It's a huge difference.
To put the severity of that timeline into perspective, the very shortest treatment time recorded for an older baby was still nearly 2 months longer than the shortest treatment for a young baby.
Man.
And this raises an important question about the practical realities of what we're asking of these families. A 6.5-month treatment plan is a staggering commitment when you look at the day-to-day requirements.
Right, because these helmets aren't worn for just a few hours a day like braces or something.
No, not at all. The standard medical protocol requires the helmet to be worn 23 hours a day.
23 hours?
Yes. The infant sleeps in it, plays in it, eats in it, and sweats in it. You only remove it for 1 hour a day to bathe the baby and rigorously clean the helmet with rubbing alcohol.
To prevent skin breakdown and odor, I assume? So, if you start treatment during the golden window at 4 months, you might be entirely finished before the baby is even crawling. They barely even register that the helmet is on.
Right, they just adapt.
But if you start at 12 months, you're trying to wrangle a walking, highly active, highly opinionated toddler. You have to keep a helmet on a toddler for 23 hours a day for over half a year.
And that is exactly where the Grigsby study noted the real-world friction. Parental compliance becomes a massive hurdle.
I can imagine.
Many parents in the older group end up abandoning the treatment early, simply because the sheer exhaustion of managing a toddler in a helmet for 7 months causes severe burnout.
Yeah.
So, to answer the listener's third question, yes, helmet therapy works beautifully after 12 months, but it requires double the time, double the effort, and just an exponential amount of patience.
So what does this all mean? Let's bring this wealth of medical literature back down to the ground for you, the listener, navigating these decisions.
It's a lot to take in.
It is. But basically, if you have concerns, seek an evaluation during that 3 to 6 month golden window so a clinical team can officially rule out craniosynosis.
Exactly. Get the experts to check it.
Right. And if it is positional plagiocephaly, know that a 2-month period of conservative treatment like stretching tight neck muscles and prioritizing tummy time is standard and highly effective for mild cases.
Very effective.
But if the asymmetry is moderate to severe, the data clearly shows that helmets provide vastly superior outcomes. They protect the child from downstream jaw and visual field complications.
Which is huge.
And finally, if you find yourself at the 12-month mark, you have not missed the boat. The FDA and clinical studies confirm you can achieve the exact same perfectly round destination. You just have to be prepared for a much longer journey to get there.
Before we go, there is one final piece of historical context buried in your sources that will fundamentally change how you view this entire topic.
Oh, what's that?
We discussed how prevalent positional plagiocephaly is today, but it wasn't always this way. The massive spike in flathead syndrome actually began in 1992.
1992? What happened then?
The literature ties it directly to the American Academy of Pediatrics Back to Sleep campaign. By aggressively instructing parents to place infants exclusively on their backs to sleep, the campaign achieved an unmitigated public health triumph. It reduced the incidence of sudden infant death syndrome by 40%.
Wow, 40%. That's incredible.
That's a monumental victory. But we traded a fatal risk for a mechanical one. The incidence of plagiocephaly skyrocketed 5-fold as a direct result.
5-fold. So by solving one massive physiological threat, we unintentionally physically reshaped a generation's skulls.
Exactly. It necessitated the creation of an entirely new field of pediatric orthotics just to manage the ripple effect.
That is wild.
It is a profound testament to the trade-offs in medicine and something really fascinating to ponder the next time you see a baby wearing a cranial helmet.
It certainly reframes the entire experience. Well, thank you for walking through the mechanics of this research with us, and thank you, the listener, for providing such an incredible stack of sources. We hope this gives you the definitive clarity you need. Until next time, thanks for joining us on this deep dive.